Thanks very much. Can everyone hear me? Great. So, as been said, I'm going to give a brief overview of the results of the online survey consultation that we undertook as part of our ongoing maternal and child health neonatal project. For those of you who aren't aware of the consultation that we did, Health Scotland actually initially undertook a review of the literature, let's go to that, in the subject area. The literature was used to inform the evidence-based statements that were included in the online consultation survey, and you're going to see them just after I've stopped speaking. We're going to go back to those survey statements. The SISSC team worked with Health Scotland to develop the evidence-based statements, and we assessed the quality of the evidence using something called GRADE, and the questionnaire was piloted with a number of stakeholders, and then it was distributed widely across Scotland. So we assessed the quality of the evidence to provide a ranking for the evidence statements, and they were ranked into effective actions supported by high quality evidence, promising actions supported by moderate quality evidence, promising actions where there was weak evidence base, and actions that are likely to be ineffective. We used GRADE, which is a grading of recommendations, assessment, development and evaluations, which is basically just a systematic approach where you grade the quality and the strength of the evidence based on the methodology, the consistency of results, how generalisable the results are, and how effective the treatments have been shown to be. The questionnaire asked respondents to assess the evidence statements on their likely impact, from most to least impact, feasibility of the action from most to least feasible, and whether the action was actually currently happening within their current practice. We had 75 respondents who answered the majority of the questions, so the data I'm going to show you, there's very little missing data, and this presentation only gives you a flavour of what we found. It isn't comprehensive, we haven't analysed all the results, but we wanted to share some of the results within the workshops. So you will see more of these results when our report's published. So this table shows what the respondents' current role was, and you can see from the table that most of the respondents were neonatal nurses or midwives qualified in specialty or were registered child nurses. The following few tables show the valid percentage of respondents rating each statement as high impact, so that's 4 or 5 on the 5-point scale. High feasibility, again 4 or 5 on the 5-point scale, and whether they were undertaking the action in current practice. I've circled in red those actions which have been given the highest impact and highest feasibility and where it was reported in current practice. Hopefully it'll make a bit more sense when you see the table. So these are actions that are supported by high quality evidence and are therefore likely to be effective. And what I've highlighted are those actions perceived as highest impact, highest feasibility, and because they're high feasibility, they're most likely to gain early traction. Some of the tables, you'll see the actions are seen as having less of an impact. So for example, statement 5, or as being high impact but less feasible. For example, statement 1. In these cases, more would have to be done to implement these changes into current practice. So in this table, the first 4 statements refer to skin-to-skin contact, but they vary in terms of factors related to the baby's birth weight. For example, low birth weight under 1,500 grams in statement 1, those under 2,500 grams in statement 2. The frequency of contact, so whether that's intermittent or daily, and varying durations from 10 minutes to 2 hours to any duration. So these figures seem to suggest that skin-to-skin contact is seen as having high impact. It's seen as highly feasible by many, but this seems to be moderated by the birth weight of the baby, the frequency and the duration of the contact. And it's not universally current practice in Scotland yet. This table relates to actions which are supported by moderate quality evidence and are therefore promising. Those actions which are seen as high impact and highly feasible were providing breastfeeding support combined with specific messages and providing staff training and education. This table relates to actions which are promising but where the evidence is weaker. So respondents thought the use of certain techniques to increase the quantity of milk produced would have a high impact, and that social and informal interaction between staff and parents was highly feasible and is actually already happening in many units. Finally, this table relates to actions where the evidence base suggests that the actions are likely to be ineffective. And in this question, we asked respondents to ask what they felt would be the impact of abandoning these practices. And I've highlighted the do not abandon column, as I think that's probably the most interesting. So we have people saying that you shouldn't abandon it despite the fact that there's evidence that it may be ineffective. So, for example, a quarter of respondents thought that abandoning cup feeding would have a negative impact despite the evidence not supporting that. Okay. We included a series of open-ended questions in the survey in which we asked respondents to provide examples of other effective actions, to identify barriers, to implementing evidence-based actions, strategies for overcoming the barriers, and to share some good examples. The tables are not in any way ranked. They're just a list of the themes that we picked up from the initial data. I'll pick out a few examples from the data, but that doesn't mean they're any more important or less important than any others. They're just commonly referred to. And there may well be more themes that you feel are more relevant to you in your context, and we'll have the opportunity to discuss that later on. So this table relates to actions which might improve the promotion of breastfeeding in neonatal units. So I'll give you a minute to just have a quick look at those. So just pick out some of those: communication, education of staff and parents, and improvements in the physical environment were repeatedly noted. In this table, the actions relate to those that might improve the promotion of breastfeeding in neonatal units, particularly in relation to vulnerable groups. So it's the same question as before, but just in relation to vulnerable groups. So you can see the themes are similar, but they also included providing wide-ranging support in the form of financial support for travel costs, social and peer support, and interagency and multidisciplinary support. We asked respondents the same questions, but in relation to the promotion of parent-baby attachment. Again, I'll give you a few seconds to have a look at those. Again, communication, education of staff and parents, improvements in the physical environment came up again, but there's a greater emphasis on facilitating parents being present, for example, through open visiting or facilities for parents to stay. In terms of promoting attachment in families from vulnerable groups, support again was key, as was staff training and awareness of vulnerable group needs. When asked about barriers to promoting change, a lack of appropriate physical environment, lack of staff training, skills mix and numbers, and communication were often cited. When we asked about actions that might overcome those barriers, some of the actions included things like staff training, involving and empowering parents, and identifying and providing support. Examples of best practice included the UNICEF standards, the family integrated care model, and person-centred care. Finally, general comments related to helping parents to take ownership and improving staff skills. So very consistent with what others have been saying this morning. And that's it. Thank you.